Welcome to the first mini lecture of the curriculum on the management of alcohol use disorder. Today we're going to go through a whirlwind tour of psychosocial interventions. Some people may already be familiar with the IMPitt model, which stands for Screening, Brief Intervention, and Referral to Treatment. IMPitt is an evidence-based approach to identifying patients with at-risk alcohol use and encompasses a model for providing brief counseling to patients who are drinking more than the recommended amounts. However, for many patients with alcohol use disorder, brief intervention is not enough. For the next couple of weeks, we're going to be focusing on the last phase of IMPitt, which is that referral to treatment part of it, as well as the treatments that we ourselves can provide as internists. It's worth noting that even though we're talking about this during clinic time, we should also be talking about this with our patients who are admitted to the hospital for alcohol-related complications. The experience of being hospitalized for an alcohol-related complication can be a really powerful trigger to motivate behavioral change. When we're thinking about referral, we need to understand that treatment intensity can and should vary between patients. While we may not make the final decision on who should attend, say, intensive outpatient versus who should attend residential treatment, it's really important to know what level of treatments exist. ASOM, which stands for the American Society of Addiction Medicine, presents a 4-level continuum of care, though it actually weirdly starts at the 0.5 level of treatment. At this half stage of treatment, people with at-risk alcohol use are receiving brief, early interventions, that BI part of the IMPitt model that I already alluded to. Level 1 takes place in the outpatient clinic. At this level, patients are receiving less than 9 hours a week of treatment, and many receive a lot less than 9 hours. They may be seeing a physician for medications and a therapist for counseling, but they're often still going to their regular jobs or fulfilling their routine responsibilities during Level 1 kinds of treatment. Level 2 involves intensive outpatient and partial hospitalization. Intensive outpatient provides between 9 and 20 hours of total treatment per week. Partial hospitalization involves more than 20 hours a week spent in treatment. Patients can achieve recovery with these interventions, and some never need residential treatment programming. However, residential treatment programs are helpful for some people. These programs provide 24-hour supervision and treatments every day of the week. Residential treatment programs don't need to have physicians or nursing staff on site, even though they are providing 24-hour supervision. The programs usually aren't staffed to support patients with really significant mobility limitations, unstable psychiatric disease, or complex medical needs like oxygen or NG tubes, PICC lines, that kind of thing. Also, patients with significant cognitive limitations or unstable psychiatric disease may need to have those conditions addressed first. Otherwise, they won't be able to engage with the cognitive work that's done at all 3 of these levels that we've talked about already: outpatient, intensive outpatient, and residential treatment. Finally, some people require medically monitored settings that can help manage the potentially serious complications of alcohol withdrawal. This is the treatment setting where we often see many of our patients with alcohol use disorder. It's important to note that medically monitored withdrawal management doesn't usually change outcomes unless it's also linked with additional recovery services that help the patient develop the skills they need to stop or reduce their drinking once they're back in their old environments. Deciding between these options can be tricky and honestly is often not the responsibility of the internist. That being said, it's worth knowing how an addiction specialist might make this decision. ASOM recommends that an assessment focus on 6 factors. Obviously, patients at high risk for withdrawal may need a higher level of care to start. Similarly, people with significant medical or mental health comorbidities or who have struggled with relapse during treatment in the past may need more intensive treatment. Finally, people with profoundly unstable living or housing situations often do better in residential treatment programs. So, we've thought a little bit already about the intensity of treatment that a patient may need. Next, let's talk about what forms these treatments can take. Well, there are really 3 forms of treatment that are available to patients with alcohol use disorder. Patients can get involved in mutual support groups, things like AA. Or they can enroll in formal addiction counseling programs. Or they can start medications to increase their chances of recovery. Actually, even though I linked that list of 3 by the word or, really these treatments often work best in combination with each other. So maybe I should be saying they can do mutual support groups and formal addiction counseling and medications. Today, we're only going to talk about the first two choices, mutual support groups and psychotherapeutic approaches. Stay tuned until next session to learn more about the medications that we can offer. Let's start with mutual support groups. By definition, mutual support groups are non-professional organizations that offer peer-to-peer support for people struggling with alcohol use disorder. Because there aren't therapists or specialists involved in these groups, they're usually free. The most well-known mutual support group worldwide is Alcoholics Anonymous, or AA, which promotes abstinence through meetings, mentorship with a sponsor, and the 12 steps of recovery. AA helps many people, and the wide availability of meetings is a great advantage of the program. However, some people are interested in learning about alternatives to AA and find these alternative groups to be helpful. None of them have been as widely studied as AA, and none have as many meetings available as AA does. However, all of them have an online presence, including 24/7 support boards and chat groups to help address access issues. Many people who are involved with these groups are also attending AA meetings from time to time. The oldest and best established alternate group is Women for Sobriety. It's the only mainstream mutual support group exclusively for women and trans women, though some AA meetings are women only. Women for Sobriety focuses on 13 affirmations to help women in recovery. Like AA, Women for Sobriety promotes abstinence from all alcohol. LifeRing grew out of concerns about the spiritual aspects of AA. LifeRing describes itself using a 3S model: sobriety, self-help, and secularism. Like AA and Women for Sobriety, LifeRing is abstinence-based. However, there are no core steps or affirmations in this program. Smart Recovery is another secular group. It tends to attract a younger crowd, and it's one of the newer kids on the block when it comes to mutual support. SMART focuses on a 4-point program that addresses building and maintaining motivation, managing urges, managing thoughts, feelings, and behaviors, and living a balanced lifestyle. Most people in SMART Recovery are focused on complete abstinence, but the group does accept people who don't want to pursue complete abstinence and are instead working to reduce their alcohol consumption. Finally, Moderation Management is a group that offers strategies and support for people who are looking to learn how to drink in moderation. The group is really clear, though, that moderation is not the right choice for everyone and actually may be more difficult to achieve than complete abstinence. According to MM's website, about a third of people who start working on their alcohol use with moderation management end up pursuing abstinence goals. Okay, so we've talked about mutual support groups for folks with alcohol use disorder. Now let's talk about therapeutic models that are used for patients with alcohol use disorder. While I don't have the skills or the training to offer these treatments, I think it's really helpful to have a basic understanding of the evidence-based therapies that exist. Cognitive behavioral therapy is perhaps the best known and aims to help patients recognize and reframe unhelpful thoughts. 12-step facilitation is designed to help patients buy into the idea behind 12-step programs and to get involved with a 12-step group for ongoing support. Finally, motivational enhancement therapy uses motivational interviewing techniques to elicit and bolster behavior change and change talk. Many programs incorporate elements of all three therapeutic approaches, and they can be woven together very well. There are also a few other evidence-based treatment modalities that we're just not going to have time to cover here today. Let's finish up with just 2 brief practical tips on how to help patients who are interested in engaging with treatment. The reality is that a lot of patients who are interested in engaging with treatment end up choosing recovery services based on cost, insurance eligibility, and bed availability. However, there are places where maybe a patient will have a choice between 2 different rehabilitation facilities, and it's worth thinking about the guidelines that exist about markers of high-quality care. SAMHSA, which is the Substance Abuse and Mental Health Services Administration, suggests looking at 5 components when evaluating drug and alcohol treatment programs. It's important to note, though, that a lot of patients have done really well at programs that don't have all 5 criteria, and these are just markers that potentially signal higher quality care, but aren't mandatory for a patient to make a successful recovery. The first marker that SAMHSA talks about is credentialing. All treatment facilities are licensed by the state before they can see patients, but the bar for licensure is not federally standardized, and so may vary between, say, Massachusetts, Pennsylvania, and Florida. There are 2 main credentialing bodies that are more nationally standardized: the Joint Commission, which we're all familiar with because it credentials our hospitals, and CARF, or the Commission on Accreditation of Rehabilitation Facilities. Like I mentioned earlier, not every great facility is credentialed, but many great facilities, even if they don't hold credentialing from the Joint Commission or from CRAF, do have at least some counselors and physicians with specific credentials in addiction medicine. Next, let's talk about comprehensive assessment and personalized plans. Do all of the patients in this program have the same duration of treatment? That at first sounds like it would be a marker of good care, but it might suggest that program isn't providing personalized treatment plans or a comprehensive assessment. For example, a patient who relapses during treatment may need a little bit more time in treatment. What about comprehensive assessment? Does the center think about and ask about other medical and psychiatric conditions or help with other parts of recovery, like establishing housing, referring to vocational resources and training, family needs, spiritual needs? Some programs are designed to help patients overcome specific barriers to treatment and provide childcare or allow children to live with their mothers while the mothers are in residential rehabilitation. All of those things are markers of comprehensive assessment and personalized treatment planning. High-quality care should offer some forms of evidence-based therapy, things like the evidence-based treatment modalities that we talked about during this lecture, as well as medications when appropriate. It can be tough to tell on a website what kinds of therapy is offered at the center, but that is a question worth asking during the enrollment process. Finally, high-quality care recognizes that recovery from alcohol use disorder and any other substance use disorder takes time. Programs should help patients plan carefully about ongoing support when they transition to a less intensive level of care. Lastly, access can be difficult for many patients due to cost and insurance eligibility. Many programs will work with patients to apply for Medicaid, or they'll offer some scholarships for patients with limited financial means, though those scholarships are often small and may not cover all of the costs associated with treatment. For patients who are worried about taking time off work in order to attend treatment programming or attend follow-up appointments, it's worth noting that FMLA can be used to cover time needed for treatment programs and follow-up appointments related to alcohol use disorder. There are some really important caveats to that FMLA for alcohol use and substance use disorder treatment, so I would recommend talking to your patients really carefully before you fill out that paperwork, and maybe even involving social work if you think it might be helpful. Okay, we've gone through a lot of material today. Let's just recap the key points. First, we talked about a spectrum of treatment intensity ranging from outpatient to medically monitored withdrawal management, and we know that some patients do very well with outpatient services alone. Treatment can include mutual support groups, therapy, and medications. There are a number of different kinds of mutual support groups, including AA, and groups that are secular, like LifeRing and Smart Recovery. There are also groups that are supportive of moderation or harm reduction goals, such as Smart Recovery and Moderation Management. We also talked about evidence-based therapy models, including CBT, 12-step facilitation, and motivational enhancement. Finally, we talked about markers of high-quality addiction treatment programs and how to use FMLA to enable a patient to attend treatment. Thanks so much for your attention. I look forward to seeing you next time when we'll talk about pharmacotherapy for alcohol use disorder.